Hey, my name is TJ. I'm a person in long-term recovery. For me, that means I have not had a drink or a drug since August 9th, 2016. I'm here hosting the Recovery Matters podcast with
Chad McDonald.
Hey, thank you so much for coming on today. I think that you are by far one of the most knowledgeable individuals on addiction recovery, especially from a clinical, medicinal standpoint. I think that you also have one of the best passions of people I know. So you want to tell me a little bit about your background?
Sure thing. So I practice addiction medicine and family medicine.
Okay.
And I work with Intercommunity in the Hartford, East Hartford area. And I do everything from inpatient, like detox, withdrawal management stuff, to residential stuff, to in clinics, and giving, helping patients who are thinking about or are ready to make changes toward recovery, to make those changes and to know what their medical options are.
Yeah, that's really awesome. I was really intrigued when I heard you started a detox for cocaine.
Yes.
Tell me about that.
Yes. So historically, that's something that nationwide that hasn't really been offered. Connecticut as well. And due to some recent changes in things at the state level, suddenly we can offer that service. Even before that, cocaine has been a problem in our country, and especially in Connecticut, especially Hartford, for decades.
Yep.
Decades. People have needed help, but it's been seen as this thing where, oh no, you don't need a detox from cocaine. It's just a mind game, or it's not a real withdrawal. That kind of BS stuff. So it was really nice to be able to finally offer that, especially since, if you look at the numbers on even the state's website, Connecticut has a major cocaine problem. We have an opioid problem, no question. Alcohol problem, no question. We have a real cocaine problem.
Yeah.
Even more than other states, even more than Hartford, more than New Haven. Connecticut has a cocaine issue, and it's really nice to be able to have another thing to offer people to get out of those situations.
Yeah, I think one of the big unspoken pieces of that is okay, it's a stimulant, right? There's no true physical withdrawal symptoms, right? And that was the first understanding. And then I'm having conversations with people like legislators, all these people, and they're like, well, this person doesn't need a detox program. And it's like, well, have you ever actually smoked crack for 15 straight days? And they're like, well, no. And I'm like, so how would you know? They're like, well, scientifically speaking. I'm like, I'll tell you right now, as a person with prior crack cocaine use, I would go on a crack run. I need to be somewhere. I need some medication. I need to sit down and eat a sandwich and rest, and get to feel better physically before I can actually make some true decisions on my life.
Right.
Yeah.
And I think that's the nuance here is there's specific FDA-approved medications we use for alcohol withdrawal. There's FDA-approved medications that we use for opioid withdrawal and for those use disorders or addictions, but we don't have that for cocaine. So it's seen as if there's not a medical indication, but you and I know, so many patients live in situations where there's active cocaine use and everyone around them is using cocaine, and they've been trying for years to just stop, but that's where they live. So, and people feel it. You can attest when you stop using cocaine, when you've been using a lot of cocaine, there are medical issues that come up.
Yes.
You crash for a few days. You feel terrible. And that and so often, our cocaine use covers up other issues that rear their head. So you need to do it in a place that's safe and comfortable, because there are withdrawal symptoms and things that come up.
What would be a typical treatment protocol for somebody coming in off a cocaine bender, crack bender, somebody coming in seeking help for their cocaine use?
Yeah, that's the challenge, is that there's no FDA approved medication for it, right?
Okay.
So when we're talking cocaine withdrawal, it's really more, it's comfort. If you're particular, and everybody's a little different, right? So for For Joe, his issue with cocaine withdrawal might be that he feels anxious. So maybe he's going to use more of the as needed medications for the anxiety. Or maybe for Sally, she gets really nauseous and she's used to having cocaine. She just gets a cough or whatever the symptoms are. The aches and pains come back.
Yep.
Whatever it is, we focus on comfort. It's not like with opioids where we're starting methadone or we're starting Suboxone, buprenorphine, or with alcohol where we're starting naltrexone or something. It's more comfort, and so much of cocaine use is getting back to, getting back to the joys in life.
Okay.
And being able to find simple joys, right?
Yep.
So people tend, when we use cocaine, our ability to derive joy from things like going on a walk, talking to a friend, watching a movie, having sex, those things don't have the joy they had before because literally our nerves and brain are rewired. So with cocaine, yes, there's the withdrawal period. And then even beyond the withdrawal, what do we do? You finish alcohol with Detox. What do? Go to rehab.
Yep.
Well, with cocaine, why wouldn't you need to go to rehab?
Yeah.
Why wouldn't you need to, we know that one of the few treatments that has decent evidence is things like contingency management, right? We're learning how to value things in our life beyond cocaine.
Yep.
So it's a lot easier to do when you're in a facility that's inpatient and there's a schedule and there's trained clinicians there to help you than to try to do it at home when there's active use going on all around you.
Yeah, and going to a cocaine detox gives you the ability to break the cycle that you're in and get to that next level of what does life without cocaine look like, right? What draws you personally to medication-assisted treatment and working as a doctor in the field of addiction medicine?
So, like all things, we all have a draw to the field. Most people don't work in the field without some connection. I have a lot of family history of different substance use, and that's what got me interested in the field.
Okay.
I got through school studying family medicine, and it took till we lost yet another family member to yet another substance-related death where I started looking into it. And so I started, I had a full-time practice, family med, did the research, started looking into addiction medicine, tried it out, loved it. And what I love about it is people can go from, okay, I'm ready to do it. I'm done using, I'm ready to get onto a medication that can help me feel like I can do this. And do it and start my recovery path. And I love that feeling of a patient coming in feeling terrible and not knowing if they can do it. We have a conversation of the options. They see what's best for them. They start it, and it's nearly immediate.
Yep.
I mean, you don't get that in most of medicine.
Okay.
So I guess you could say it's kind of a rush, right? It's kind of the rush. It's the rush of treatment.
Yeah.
In that we start something, there's immediate results, and that element, whatever the substance is that is controlling that person's life, is more controllable.
Wow. Just
with a medication.
Yeah.
It's not a silver bullet. You and I know.
Yes.
That's why it's, we used to call it medication-assisted treatment. There's therapy and other things that go part of it, 12-step programs. If you want to succeed, you got to use the whole toolkit. That's the thing.
Medication is assisting your treatment in recovery.
Exactly.
Right? And I want to ask you about stigma. Do you deal with people who face stigma a lot, right? Like people come in and they have this preconceived notion of I can't be on this because I'm not going to be sober, or this isn't going to work for me, right? Or people in the recovery community aren't going to accept me because, or I can't go here, Tell me some things about that stigma.
I see that all the time. I see that with family members. I see that among healthcare workers, politicians, and unfortunately, the hardest one, the saddest one, is I see it with patients.
Yep.
I'm sitting in a room with somebody, and they could be, working on this for a year and they have a slip up. And what do they tell me? Doc, I'm dirty. That kind of word choice, right? I'm dirty. Just because a urine is positive because they had a slip up, which statistically is going to happen, right? Statistically. And says, I'm dirty. I'm not clean. It's these words that we use, and I see patients using them, and I try to be gentle, but I try to correct it because, I don't say to the diabetic who ate a donut, oh yeah, you're dirty.
Yeah. Yeah.
I mean, that's messed up. So I see that stigma just in word choice.
Wow.
And I see the stigma in, you go to that place, you're on Suboxone, you're not really clean.
Yep.
You're on methadone, you're not really clean. BS, right? That's garbage.
Yeah.
And so I think it's really important in the recovery community that we are examples with that.
Yes.
And even with our word choice, that we're careful. And
So as a person who, for me, so I've been recovering for 9 years, right? Yeah. So I think that, Suboxone never worked for me, right? Yeah. So for me, my issues were a little bit different than just like the typical person who can come in. It's like, okay, this can stabilize my life. I think that Suboxone was something that triggered something within me that like made me want to use other substances, right? So part of me was, I have post-traumatic stress disorder and I have a couple of other, issues in my life, right? And like, I dealt with that stigma, right? Where it was like, depression, anxiety, right? Like going to the doctor and like actually having this conversation with somebody who's poised to have this like, hey, look, this is my issue. What are my options, right? And like for me, it was like I go in there and like I had a preconceived notion that like, I was dealing with anxiety, depression, and I go in and I'm discussing this, and they're like, okay, like there's options for this medication, right? Like venlafaxine, it's a typical SSNRI, right? This could be very beneficial in your life, but there's this period of time that it's going to take you to get up to a dose that you'll see a positive effects. Like your anxiety might get worse before it gets better. Yeah. Right. So I'm like, oh, here we go. This is exactly what I'm talking about. You people and the medication, and it's going to get worse. It's like you guys are a part of the problem in this country. And like this whole thing, right? And it's like, and then I give the medication a shot. 2 weeks later, like my life is literally better, right? Like I'm no longer having full blown panic attacks, right? Like I'm able to function like my excessive compulsive. Like I'm not checking the knobs or doing the counting methods, right? Like not obsessing about things like. Looking at that in a way of treating somebody comes in and it's like, doc, this isn't going to work for me, right? Yeah. And it's like, you have those experiences, right? Where you're able to work through it with somebody and like go through all the options, right? It's not a one size fits all, right?
100%.
Yeah. What's that like?
So it's a very common thing, right? Because I like to call it the driver of addiction or a driver of use. Okay. And I look at it that way because every person who is struggling with substances, there's some driver of the use, whether it's maybe you're a rare where there's not an underlying medical issue and you just derive joy out of it. Well, your driver is you're seeking joy. Okay. For most people though, why are we using substances? We use substances because we're trying to escape some symptom, anxiety, depression, loneliness. Maybe you're homeless living under a bridge and you're trying to escape reality. Very understandable, right? Yes. So every person that comes in, it's very unique. And there's so much history of trauma with nearly every person who struggles with the substance. Yeah. So it's creating an environment of trust where that person can tell me or give me clues to their driver. Okay. And not everyone's there when they come in, and that can take time. So in your instance, it's great that you were able to do that in the outpatient, semi-outpatient setting. From the sounds of it, that's the beauty of something like a cocaine rehab is you're going to have therapists around there. You can't leave if you're suddenly getting a craving and you want to go use cocaine. you're in a facility. And this therapist can help you live deal with this until those medications kick in.
Yep.
And you can get as needed meds. If that 2 weeks isn't practical for you because you're struggling extra hard, you're going to get there because you're in a place where we can help you. So sometimes, and it's very common when we're in active use, a lot of patients don't have the insight into what their driver is.
Okay.
And a lot of times when patients stop using substances, suddenly issues pop up.
Yep.
Right? Like, the classic one is person stops using cocaine. That's awesome, but the voices are back.
Yep.
Right? And that wasn't even in play because the cocaine was covering up everything.
Okay.
So a lot of times there is not a silver bullet. There's not a one size fits all. And it's figuring out, it's a discussion. I know the numbers and the probability that X will help you reach recovery. You're going to have X, you're going to have Y% rate of success at 3 years. But if you're not willing to take the Suboxone film in your mouth every day, then what's the point? We need to talk about what's realistic for you.
Mm-hmm.
You need to understand all the options. And I'll tell you, you're going to be more likely to succeed if you do an injectable buprenorphine like Suboxone or Brixadi than if you're doing nothing.
Okay.
But at the end of the day, that's your decision and you have to be ready. So it's all about explaining options, listening to the patient, figuring out what the heck we're going to do.
Mm-hmm.
And then there's all the, that's all the medical. And then there's all the social determinants, right? So.
Yep. So I'm thinking a lot about a lot of things here, right?
Yeah,
So specifically Suboxone and Brixadi, right? These are new. You kind of want to give me a breakdown of what they are specifically?
Yeah, absolutely. So for opioid use disorder, opioid addiction, traditionally for years now, it's been Suboxone has been the big name, which is buprenorphine, which is, you can think of it like a partial opioid, right?
Yep.
It's not a full opioid. Don't tend to get high with it. It's just kind of keeps the withdrawal away. Well, then they came up with an injectable form. First one to market was Suboxone and later on Brixadi. But these are injectable forms that slowly, 24 hours a day, 7 days a week, after they're injected, release tiny amounts of buprenorphine, that partial opioid, so that the cravings aren't there. And so that you don't have to wake up. A lot of patients say they wake up and the first thing they do is they start their Suboxone because there's a little bit of time where they don't quite feel right. Suboxone's built to last all day, but it has to start kicking in. Well, with the injectables, you don't have to worry about that. You wake up, it's already at full dose.
Wow.
You have to deal with the film dissolving. You don't have to make sure your films are locked away in a safe so no one steals them.
Yep.
You don't have to deal with any of that headache. And you can focus on the therapy and get into those NA meetings instead of on making sure that you're getting all your strips. So it's been a game changer. And
wow.
Fentanyl has made it a little more challenging for people to get onto it.
Okay. What are those challenges you face with somebody getting on fentanyl or getting off of fentanyl onto injectable?
Yeah. I mean, we could do a whole podcast on that topic. But the short version is fentanyl, not only do we all know, well, I should say most people on this podcast are likely aware fentanyl is a very strong opioid, way stronger than heroin, right? And it's basically the most common opioid in America today, if you're looking at urine results. And it's really strong, and it really likes our fat cells, so it tends to stick around for a while.
Okay.
And because it likes our fat cells and it can do things within our body, it makes it extra hard to start Suboxone the way we used to with heroin. They're just totally different chemicals, right?
Yep.
So it makes it harder to start Suboxone. And it used to be that, you had to go into a full withdrawal. Then you could start Suboxone. Otherwise, you get the precipitated withdrawal.
Yep.
And then after a week on that, then you could get the injectable buprenorphine like Suboxone or Brixadi. Yep. And so that was kind of an issue. Well, with fentanyl, everyone metabolizing it differently, you could no longer say, okay, stop using fentanyl for 24 to 36 hours and then come back and we're going to sit here in the office until you've withdrawn. We couldn't predict it. Because
Okay.
some people would wait a week and they wouldn't withdraw. Some people would 6 hours, they'd withdraw.
Yep.
So fentanyl made it really challenging. So we had to come up with these other ways. And so this a term that some people use called microdosing. We prefer calling it low-dose bupe because, again, getting back to word choice, we don't want to be using words that we associate with illicit drug use in the medical community, right? So low-dose buprenorphine induction, LDBI.
So you would start somebody at 2 milligrams to see how they react before getting them up to a more therapeutic dose?
Yeah, well, without getting into like exact numbers and details, it's basically while people are still on an opioid, they're still taking a full opioid, we sneak in very small amounts of the buprenorphine, the Suboxone.
Yep.
Tiny, smaller than 2.
Okay.
Really tiny.
Yep.
And what we're doing is we're slowly creeping up the amount of Suboxone, buprenorphine, that's in their system. And the Suboxone is slipping in and taking the space of some of the fentanyl, a little more of the fentanyl, but in the background, very, very slow until by day 5, 6, 7, we're at a full dose of Suboxone. We're not taking any more opioids anymore besides that.
Wow.
So we've kind of, like where I work in our community, we've incorporated that into our Detox, our withdrawal management.
Nice.
And so that's been very successful. A lot more people that have wanted to get onto Suboxone but couldn't now can that way. And we also do it in the outpatient setting.
Okay.
So, and again, if I could go for an hour on just low-dose bupe, and I don't want to bore people, but even if people are really heavy into fentanyl use, and we're talking bundles or a ton of baggies a day, you still can get onto Suboxone. And that we didn't used to be able to say that confidently. And now I could confidently say, not only can we get onto Suboxone, we can get you onto an injectable.
Wow.
Most of the time within a week or 5 days.
Something I heard you say was the injectables now have a higher success rate than just the sublingual films, right?
Yes. A lot of that's anecdotal. I don't know the exact numbers, right?
Okay.
But if you think about the challenges of remembering to take your Suboxone every day the exact same way for the exact same number of minutes, letting it dissolve, that's very challenging. Especially, that's really challenging for someone who's fully functional, let alone someone who's just quitting using fentanyl. That's tricky.
Mm-hmm.
Moreover, it's like you get the constant levels 24/7. So it's just kind of common sense that it works better. However, if you had somebody taking Suboxone perfectly, then maybe it would be comparable.
Okay.
The less things that we have to ask someone who's new in their early recovery to do, like remember to take Suboxone every day, the better. Because to me, it frees up a person's mind to be able to focus on therapy, focus on 12 steps, focus on getting a job, focus on getting housing.
Mm-hmm.
I mean, instead of just remembering to take your films every day.
Yeah, they'll be able to focus on like the recovery capital, right? The things that help them sustain recovery. What other options would somebody have outside of the world of Suboxone?
So if I could, and if everybody could qualify for it, I mean, Vivitrol, right? Or naltrexone is
What
awesome.
is that?
Naltrexone, so I was talking about Suboxone and methadone. Those are opioids. They're in and of themselves, they are opioids. They're maintenance opioids. But why, the argument, why would I trade one drug for another? You hear that all the time in the rooms. And the difference is the FDA is controlling exactly how much buprenorphine is in every film and how much is in every drop of methadone.
Yep.
So there is quality control, and we know exactly how much it is, and we can control the quantity. Whereas you're buying a bag on the street, you don't know, is it fentanyl? Is it a fentanyl? Because there's many different types of fentanyls. You don't know what you're buying. So that's opioid maintenance is what we call that if you're on Suboxone or methadone. Now, Naltrexone's an opioid blocker.
Okay.
So it's not an opioid at all. So you may go, well, that's great. Then why doesn't everybody get on that? Well, there's a little bit of time where when people stop using an opioid, we still have a ton of opioid in our body, in the bloodstream, on those opioid receptors. And that naltrexone works by kind of going onto those receptors, connecting, almost like opioid grabbers, and it connects. But it wants to connect so bad, it'll just knock off any fentanyl or oxy or morphine, whatever it finds in there, and people will go into a precipitated withdrawal immediately.
So they'll get sick if they take it too early.
Terribly sick. And we're not talking about maybe that progressive dope sick feel. We're talking about immediately going from feeling not withdrawn at all to the worst withdrawal of your life.
Okay.
So on its nose, it would be like, well, get everybody on a naltrexone. Well, it's not that simple. But, you know, when we can go that route, it's a great solution for people to be on a blocker. It's just a little complicated. It gets back to your question of, what are my options?
And I think that, like, for somebody on the outside to automatically assume that this is the pathway of recovery for everybody coming in seeking help for opiate withdrawal, right, or opiate dependence is like it's a one-size-fits-all. And it's not like that. We all know that there's multiple pathways of recovery, right? Like, and people who, like, you know parts of my story where I came into a detox program. And they give you the urine. They're like, what do you use? And I'm like, I'm using heroin, blah, 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 blah. They give me a urine test. I test negative for opiates and positive for everything else, right? So they're like, yep, we'll give you some Tylenol and some Clonidine, a blood pressure med. You can stay here for a couple of days and we'll treat you, but no Suboxone, no methadone. And I'm like, well, I'm out of here, right? That, like, the people that we're dealing with are so fragile and so fresh that they might truly, and I also believe that recovery isn't a program of intention, it's a program of action, right? Like, I might not truly intend to stay sober for the rest of my life, but if I'm going to make a decision today that's going to get me moving in a positive direction, it's literally better than anything I could have done, right?
Yeah.
So, you know, somebody getting into the world of recovery, right? Them being able to make that decision of, like, Suboxone is going to work for me, methadone is going to work for me, right? It gets them moving in the right direction, right? Like, you know, eventually, like, I wanted to stay in recovery, right? Like, eventually I wanted to, you know, really work recovery and have a family, you know, be a father, all these things. But, like, I didn't just wake up with this dramatic love for recovery, right? No, I was pissed. I was dope sick. I didn't want to be here, you know, and this was my only option. You know? And I'm sure you see that all the time.
Yeah. But you made the choice.
Yep.
You made a choice, right?
Yep.
And you showed up. You know, sometimes people show up and they know that their buddy, Sublocade, worked for them. So they've got to do Sublocade. But then they show up and their presentation's a little different than their buddy. And the doctor, even if it's a well-meaning doctor who's an expert in addiction, and they're like, actually, we can't do that for you because of X. Like, we literally cannot do that for you. Don't get frustrated. That would be a message for the audience. Don't get frustrated if the answer is, you can't do that, but you could do this.
Okay.
Hear that person out, because the very fact they're not just going along with it just to get you out of the room means that they care, right?
Okay.
So hear them out and consider what they're saying, because they could set you, to your point, you knew that you were done feeling dope sick, but you didn't know every path between there and here.
Yep.
Right? So sometimes the first step is acknowledge that you want help, show up, and then have a little humility to recognize and have ears open to hear, like, what are my options? Like, what's best for me?
Yep.
Yeah.
So one thing I definitely want to talk about too is, like, overdose deaths are going down slowly, right? And I think there's a lot of things to attribute to that. Do you think that medication-assisted treatment is a big part of that?
Yeah, well, I do think it is a big part of it. Is it the only part of it? Not at all.
Yes.
And no one who says it's absolutely because of X is correct, because no one can say that right now. No one knows. And we might never know.
Yep.
What we do know is working together is working. Okay. So we do have medications that help with addiction, opioids. We have organizations like CCAR and recovery organizations.
Yep.
We have increased access and education around naloxone or Narcan.
Yep.
Right? We're fortunate in that we live in a state where the state politicians value treating people that struggle. Thank goodness. So yes, our opioid-only overdose deaths are going down a little bit.
Okay.
However, our stimulant-associated overdose deaths are on the rise.
Wow.
So if you look at last year's data, the publicity was all, opioids are down, it's working, it's working. It's true. We need to, every now and then we all need an attaboy, right?
Yep.
But then when you look down below, those involving cocaine and methamphetamine in the overdose are actually going up.
Wow.
So what we're doing is working. We all need to both pat ourselves on the back and roll up our sleeves and keep working.
Mm-hmm.
And we need to recognize this is a moving target.
Yep.
Right? It's working now. But behind the scenes, we have people who continue to try to make more and more money making stronger and stronger opioids for the market.
Yep.
Because they want to outcompete the market. And so we're getting stronger and stronger fentanyls that keep coming in. It's going to keep happening. Okay. So we need to just keep not only keeping our tools sharp in our toolbox, but we need to keep looking at other angles here because clearly there's still a big problem.
Yes. And I think that what you've talked about here today is really, really important because as a country, we can be like, the opiate crisis. And then I worked as an emergency room recovery coach, and it's like all these people are addicted to alcohol. And it's like, well, alcohol is readily available. There's way less stigma around it, right? Like people can sometimes drink at work or drink in social functions or, whatever, right? Like alcohol can be one of the things that is constantly overlooked. And now it's like, now I'm listening to you and it's like, wow, stimulants are constantly overlooked. It's a really big problem.
It is. And nationwide stimulants are a problem, but especially in Connecticut and especially in Hartford.
Wow.
You look at the number of cocaine-related deaths in Hartford, and it's terrible.
Yeah. So what does a cocaine-related death look like? Is somebody having a heart attack because of the stimulant use, or is it mixed with other things? What is...
So that reporting is based on autopsy results. So that's from the drug screen comes back after the death.
Yep.
And not only was there really high levels of, say, a fentanyl, but there also was high levels of a cocaine or methamphetamine.
Okay.
So that's what that data means. So, and unfortunately, as a lot of people on this that are listening to this know, a lot of people co-use cocaine with fentanyl or alcohol with cocaine or, up and down combos are very common. So it's even easier to get into a territory with one substance that you couldn't even get to because you're taking the other substance. It's so easy to overdose.
Yeah.
And alcohol is a good point. I mean, alcohol and cocaine have been problems steadily for decades. I mean, alcohol for...
forever, right?
Yeah, centuries. And it just gets overlooked. It's legal and it has a lot of money behind it, but it still is a major problem.
Yeah.
So that's a good point.
So I got two more questions for you.
Go for it.
So if you could change one thing about the system, right, like just the generalized system of addiction medicine or something that we could do to improve, what do you think that would be? Like, what do you think's or you can get into something like, what do you think is the biggest barrier or hurdle that you face to making sure that people get help?
The biggest issue in our country is a step before the addiction. It's deals around mental illness and general loneliness.
Okay.
So it's getting, we talk about primary prevention way before things even reach an addiction. Well, if we had systems in place that helped people not feel so lonely, wherever they are on their pre-addiction, in addiction, recovery pathway, we all need help with loneliness.
Yeah.
And then, that may sound hippy-dippy to a lot of people, but I mean, that's the big issue in the room, right? Much harder to solve that than to say, oh, we just need to spend 4 times more on Narcan and the problem will go away. I don't think it's that simple. I think it's a little more complicated.
Yeah.
And likely that focuses with our rising generation and getting that into schools more.
Yep.
Education around loneliness and destigmatizing those with trauma, destigmatizing those with mental illness. Love to see that. And I do see signs of that in the curriculum. I'd love to see even more of that.
That's really cool. Yeah, connection is the way out of addiction, right? Like that big study and everything like that. And I think about my early lives and, never feeling like a part of till I found substances and people who use substances like I did. And I was like, yeah, okay, like here we are. This makes sense, right? And then like it's a very difficult cycle because it's like, okay, I'm going to use substances and then the substances pick up and take off, right? And then the substances push everybody else away from you. So you end up like where you started here, but like lonely and high, and now with a substance problem, right? So it's like, the thing that made me feel so much better makes me now feel so much worse, right? So it's like that difficult part. You hit the nail on the head. I like that. And then I think about technology too, and newer generations, right? Where like, I'd call my friends and like every day in the summer we'd get up and we'd try to ride our bikes somewhere or do something, right? And, you called on the house phone and it was just a simpler time, right? Now with technology, kids, stay at home and do less. And, they're more just like, there's this fake world that lives in the internet that people are so attached to that makes you feel so overwhelmed or lonely, right? And I think that could then lead off to substance use.
Yeah, totally. Yeah, the less time on our smartphones, the better, especially to young. We're finding more and more evidence of that, the young developing brain, especially pre-23, pre-25 years of age.
Wow.
We need to really lock down smartphone use and social media stuff. But, enough people have said that. That's clear. That's clear to say and hard to enforce.
Yeah.
In our world that's really globbed onto them.
Yeah.
I see little kids even on their parents' phone. I'm going, oh gosh, no, don't do that. Get outside, like you said.
Yes.
Call up your friends. Go ride a bike. Go. I don't know.
So here's my last question for you. If somebody came in here in their first 24 hours of recovery, what do you think is the best piece of advice or support that you would give them?
I would recommend that they connect with a addiction support team, soup to nuts, not just one person.
Wow.
They need a network of people that includes a healthcare provider that knows something about addiction. Maybe there's a med that'll make it easier. They need a therapist that's a specialist in addiction. They need a recovery coach. They need a recovery team that offers a network of activities that are recovery related for them to do you're taking out this element of your life that you've been devoting 20 hours a day to maintaining your substance supply in your body. You have to replace that with something.
Yep.
So something healthy to replace that with. And what else did I forget there? Those are the good. And then, and included in that team, some kind of a community support person, like a social worker, because nearly everyone that's in that kind of a position, brand new in recovery, there's going to be some social needs.
Yep.
Housing, food, job, friends, transportation. Yeah. So you need a network.
That's awesome. Thank you so much. And thank you so much for coming on today. I appreciate you.
You're welcome. Thanks for having me.
Of course, dude. That was wonderful. Thank you.